Welcome back to Jersey Matters. I'm Larry Menti. The New Jersey state budget requires a yearly evaluation of more efficient ways to run the Medicaid program. And with a potential repeal of the Affordable Care Act, the Medicaid recommendations of the New Jersey Healthcare Quality Institute may take on added significance for 500,000 state residents. Matt Dioria is the organization's Chief Transformation Officer. Sir, thank you so much for being here.
My pleasure.
As you look at this, first let's talk about what your organization does.
Sure. We're the New Jersey Healthcare Quality Institute's a nonprofit think tank that represents a lot of healthcare interests in New Jersey. Mainly Medicaid and community health, but lots of other healthcare topics, things like out-of-network, are issues that we confront every day.
I'm always taught to follow the money, so where do you get your money?
Okay, our money comes from both grant funders. For example, the grant that we worked on, the Medicaid 2.0 project, was funded by the Nicholson Foundation. We get some grants from United Healthcare, as well as our members. We have a large stakeholder membership that includes hospitals, insurers, nursing homes, drug manufacturers. So the industry in general.
There may be, so would you say there may be some special interest money into that because of the insurers and the medical people?
Well, we would like to say is while that special interest money helps fund our organization, we are objective in our research. If an organization likes the policies we're promoting, we'll work with them to promote those policies, but if they're part of our organization and they don't like it, we still go forward.
And I say all that just to see what the playing field is.
Sure.
Because this, as you're looking at Medicaid, I imagine that's a bit of a moving target because you had an election with a surprise result. Then you had a replacement to Obamacare that looked like it was going to go through. Then it didn't even come up for a vote. Right. Now you think Obamacare is fine and you hear there may be a compromise. So all of these things happened over the last year.
Yes.
How can you make judgment?
Right. Well, what we tried to separate was the financing, which is really where the Obamacare repeal was. It was really about how's the program going to be financed? Is the expansion of Medicaid going to continue? As well as would it be a block grant? Both of those things are major changes to the Medicaid program. The areas that we were focused on was the operation of the program, the delivery of the services, the eligibility and enrollment systems, how the managed care plans administer the benefits. Those are all efficiencies, but they're efficiencies on the margin. And our recommendation, our report included 24 recommendations, but they span potentially 10 years before they're fully enacted. And so the benefit of our work will really be something that will happen incrementally over the next decade.
If we go from the Affordable Care Act to anything new, it sounds like it's going to be a block grant to the states. Do the states get less money then?
They get a fixed sum, and over time, what happens is if the cost of the program grows at a rate greater than the federal block grant, New Jersey would have to make up the difference, and that would be a real challenge given New Jersey's budget issues.
So when you come up with recommendations, do you factor that in?
We always keep it in the background. We know that Medicaid is it's a $15 billion program. It covers 20% of all New Jersey residents. It's 20% of the state budget. as you said in your introduction, every year there's an annual review to find efficiencies. What we're proposing is, and this is happening in the Medicare world, a bundled payment for, or what they call an episode of care for maternity. So right now it's paid for, there's a prenatal segment, there's a delivery segment, and there's a postpartum segment. Each provider is reimbursed separately. They're not financially incentivized to work together towards a good outcome. They all do, they're professionals. They're all working, towards the right thing.
Does that make it more costly?
No, actually it should make it less costly, and that's what the federal government found with Medicare with joint replacements. They're doing it with hospitals. So joint replacements, it's a defined episode of care. You know you're going to go in, you're going to have an admission, and you're going to have rehab. They pay a hospital the entire fee until the hospital. You work it out with the physicians and work it out with the rehab provider. That creates the incentive on the part of the providers to all work collectively towards the most efficient outcome, one that gives the patient the least amount of time, let's say, in a rehab facility where the cost per day
I think we were saying the same thing, because what I was asking was in separating the three, does that make it more costly? And yes, it does.
Yes, it does. Yes,
yeah.
I'm sorry. Yes, to answer your question, it absolutely does. And by consolidating it all, there have been studies, good studies that have shown that you can get the results that you want in terms of outcomes at lower cost. So that's the kind of thing we're working on.
How is New Jersey doing right now with the Medicaid?
New Jersey's doing better than a lot of states, but as our report says, there's still work to be done. There's other areas like telehealth, for example, the use of technology that hasn't been as widely adopted in New Jersey as it could be. We have a great recommendation to use electronic consults, they're called. So you have a primary care physician. Access to specialty care for Medicaid patients is particularly challenging. Medicaid rates have been historically low, so specialists don't participate in the Medicaid networks. So when a primary care doctor has a patient they're reviewing and they need, let's say they're a patient with diabetes and they need an endocrinology workup, they may not have that readily available. An appointment to see an endocrinologist within 2 days may not be available. What we're proposing is the use of technology. The physician, primary care physician, would package up that information, send it to an academic medical center where a resident or a skilled specialist would look at the case and respond back within 24 hours and give, essentially a review of the case and the doctor direction.
It's fascinating that everything you're talking about is bringing down costs, which I imagine is the only thing you have control over right now, if you can bring down costs. Sir, thank you so much for coming in. We said it was a moving target. Come back when we kind of know where we stand. He is the organization's Chief Transformation Officer of the New Jersey Healthcare Quality Institute.
Thank you very much.
Difficult job. Thanks for being here. That's Jersey Matters for this week. Go to our website, jerseymatters.com, to replay segments for this show or previous shows and leave your comments about what you've seen today on our Facebook page, or you can reach me on Twitter @LarryMenti or @Jersey Matters. We may read your thoughts on a future show. Again, I'm Larry Menti. See you next week.